Hello and welcome to the Orthopedics Art. My name is Khalid Awadi. I am a final year medical student at Kuwait University. Today, we'll talk about the Orthopedic Spine Examination. So these are my references for this presentation. So the quick disclaimer. So this presentation is intended for clinical medical students at Kuwait University. As usual, always adhere to your local medical school guidelines on examination and clinical skills as it may differ from medical school to medical school. And I would like to thank the Standing Committee of Medical Education, KuMSA, and the Clinical Subcommittee as part of the Kuwait University Medical Students Association, or KuMSA, for their contribution. Big thanks to the team. So, as the main objectives of this presentation, we'll start with a case scenario, preceding by an examination with look, feel, move, and then neurovascular status. Finally, we end with special tests. And furthermore, we'll continue with the common questions that you may encounter in the station. So let's begin. We'll start with a case scenario. You're referred to Mr. K, a 65-year-old gentleman who visits you at the emergency department because of back pain. Of course, you have to ask history of the back pain. After taking a proper history, you have to examine this patient in an orderly fashion manner according to his main complaint in 6 minutes. Quick note before we start the examining or telling the steps, that the cervical lumbar spine examination are similar except a few points that I'll point out in the neurovascular status and a few extra points which I'll mention later on. And always in orthopedic examination, we always say that examination settings is always start with 5 points, which is wash your hand, wipe, look, feel, move, and end with it with neurovascular status and a special test. Sometimes some examination will tell you just do the special test, don't do neurovascular status. So it's important that in surgery you have to make sure you comment on what you'll do in every steps as you go throughout the examination. It differs from medicine. Medicine, you always sometimes the doctor will tell you, examine this patient and tell me the findings later on. They don't need you to tell you what are the steps unless he told you to at the start of the examination. So always check with your doctors and the department regarding these points. Another point I forgot to mention, it's always practiced with your colleague or anyone and apply the clinical practice and knowledge on him, on your family members, as is really important since because of COVID-19 and you're not allowed to examine patients as due to the risk of having the infection. So it's ideal to practice with your colleague and or family member and apply the clinical practice and knowledge, as is helpful for you to finish the examination within the acquired time or the allocated time, and you'll be able to understand the purpose of this examination. So start with wipe, as usual. Wipe is wash your hands. W. I is introduce yourself to the patient and the examiner. A is ask the patient the permission for examination. Sorry, it's P. So I'm gonna ask you to perform the spine examination, which involves examining your back. Is that okay? Which you tell to the patient, and you expose the patient's back while he's standing. Then we start with look. As you know, look. In almost every orthopedic examination except shoulder, is you ask the patient for inspection and gait. So while the patient is standing, look at the patient from front, side, and back. So depending on which examination, if the doctor will tell you examine the cervical examination, you look only at the cervical region, in front, side, and back. But you can inspect the entire spine, which is, I think may help, because as you know, spine is related to every region. So if one region affected, the other regions will get involved somehow. So always look at from the back. So starting from the back, look for scars. Like for example, scars, correction scar, or MIS, which is a minimally invasive surgery. So this is a picture of scars that you may encounter in the clinic or in the exam, that you see an open surgery, a long scar. So which is This is very common with corrective surgeries, like for example scoliosis repair or correction. It's very common surgery, but it's a very long procedure. Another procedure which is took a strength in the spine cases is mini-invasive surgery, which helps in correcting certain deformities, certain abnormalities. Um, let's say laminectomy, for example, and sometimes spinal fusion surgeries, which is very small scars, like less than 1 centimeter per scar, or sometimes it's in millimeters, and it works wonders. Then we'll start with deformities. If you're examining from the back, always look for one thing. There's evidence of scoliosis or the letter S, as some books mention. However, never look for lordosis or kyphosis from the back. Always look for it from the side. This is very important. You don't comment on these if you see it from the back. Always see from the side. Then you look for muscle wasting, which means that if you see muscle wasting, you will encountering a prominent spinous process, which is common if a patient who had recently had surgery. Take time to the muscles to heal with time, or because of this, sometimes because of wasting from nutrition. Skin changes that you will encounter also, which is you will encounter more in pediatrics rotation, but it can be seen in the clinic, and you may be asked to point out, which is cafe au lait spots, and let's say neurofibromatosis as an example of that, and or myelomeningeal or health tuft. So the coffee au lait spots, it's basically coffee with milk. So if you woke up in the morning and you had your coffee with milk, it's the same color. This is sometimes they'll ask what's this coffee au lait spots, which I'll show you later on. Myelomeningeal hair tuft, from its name, myelomeningeal seal, it's like a bag of with meninges and myelo, which is part of the spinous nerves and the spinal cord. And when you look at this, side, so as I mentioned earlier, always look for spinal alignment, whether it's normal or lordosis or kyphosis, which I'll show you later on. That so what normally a human being have in this situation, and then look at the front. So at front you see the scars. If it's a cervical, you ask for cervical spine anterior approach, which is a small scars. You see if it's anterior approach for the surgeries. Any visible pulsations, like say for cervical, you check for carotid artery pulse if it's visible and well seen. And lumbar, you check for abdominal artery aneurysm or AAA. In cervical, you also check for another thing, contractures, which is a common thing in torticollosis, which I'll show you now in the picture. In a gait, you ask the patient to walk from the end of the room towards it, as gait normally do in hip examination and knee examination. So this is a scar, also scoliosis. This is a patient who had post-op 1 week, and she's doing well. So this is a torticollosis case. So torticollosis happened because of a contractured sternocleidomastoid, because of sometimes either congenital, born with it. So the sternocleidomastoid start to have problems. With time, it gets contracted, so it becomes like a cord-like structure because of good fibrosis and from injury, the same traumatic injury and during birth, especially during traumatic birth injury in forceps delivery, which is very very unfortunate to the child, because if not done adequate physiotherapy and follow up, he will still have this condition permanently, which will affect him. So how does the child present? So he'll be tilted to the affected side and then rotated to the contralateral side. So as you can see, he has lateral rotation on one side, then there's rotated on the other side to the right, which and there's also some say there's a chin lift, as seen in this picture. So as you can see, this is a coffee au lait spots, which looks like a coffee with milk. And this is the spine alignment which you see from the side. So as you can see from the last picture on the left, so this is our normal spine alignment. So as you can know, so the cervical, we have cervical lordosis and slight lumbar lordosis, and the thoracic and the sacral both have a slight kyphosis, which is a normal kyphosis. However, when you have an exaggerated angle, spinal angle at that area, it's called kyphosis. When you have exaggerated angle, spinal curvature at the lumbar area, that's called lordosis. And this is another example of scoliosis, as you can see from the side, and you can see scoliosis see from the back, and from the side you can see kyphosis. So this is the patient. We ask the patient to do a normal gait, that's what we talked about earlier. The ask the patient come back towards you, and then go back, observing for the alignment of the spine and the lower limbs. Now this is normal. Next, we'll go with feel or palpation. Now, a quick note before you palpate. Before you even palpate or even touch the patient, always ask the patient, do you have any pain in your shoulder? This is very important, and this is a very crucial step during examination, because it already has its own specific grade for it. If you don't do it, you will lose marks, and it's not good for you at this point. You want to be a professional, safe doctor during examination. So in palpation, you palpate for two things: the soft tissue palpation and the bony palpation. So I'll show you now in a picture. So the spine is divided into two sections. The black line, the top will be the cervical spine palpation, and the lower of the black line is the lumbar spine palpation. So first, you examine for the paraspine, for the soft tissue palpation or the paraspinal muscles, as I shown here. You palpate on both sides at the same side of the arrows as pointed out. So you go from the top and from the sides of the spine, and you palpate on both sides. We'll palpate for tenderness or spasms of the muscle, or sometimes for wasting. And for bony palpation, you palpate in the middle. You palpate the bony process for tenderness, like for example, because of fractures, because of an infection, because of a tuberculosis, which is called Patch disease of the spine, or tumor. Sometimes when you palpate, you feel like a round mass or an abnormality. Or sometimes you palpate for something called a step deformity, which is basically a fracture dislocation or significant instability at this level. So you go downwards and you palpate. Next, we'll go with the move or range of motion. So I always remind the students during the review session in the clinic. We always tell them spine examination and movement always reminds me of morning exercise at school. Those who are in government school, so مدارس الحكومية أو مدارس العربية التعليم الخاص, we do a morning exercise at school, or sometimes when you wake up early and you stretch your back after waking up a bit throughout the day. So as a patient in cervical, you always check for flexion, extension, hyperextension, rotation, and lateral flexion. So as a patient to follow your steps. So as you do it, make sure the patient follows you while you do it. This is very important, because sometimes when you tell the patient flex your neck, he'll not understand it. So show the patient what you're doing. So stand in front of the patient, do the flexion in front of him, and you see the patient if he does that. Then do extension to stretch your neck. Make sure you don't stretch it too much. You don't want to injure you want to injure the patient's neck. Then rotate. Go right. Rotate to the right, rotate to the left, then lateral flexion. Bend your neck to the right and bend your neck to the left. Now for this lumbar range of motion, you ask the patient to do a forward bending, which is flexion. So touch your toes, backward bending, extension, stretch your back. And sometimes they tell you lateral bending right and left, so lateral flexion or bending on both sides. So touch your sides. So you touch your right side, touch your left side, and rotate from the lumbar area. So rotate from the right and to the left, with keeping the pelvis and the leg. So this is basically range of motion. You want to see the range of motion if there's restriction. This is the aim of the examination. So you want to see range of motion if there's restriction, or he can fully perform the spine examination as in difference to a normal individual. For neurovascular status, so I'll advise you to read certain pages in the Orthopedics Physical Examination Manual done by Dr. Ali Charq. That's part of the Kuwait University publication. So read the following pages from 42 to 44 and from 48 to page 54. These are all important, and it will be easy to understand once you go throughout every step of the way. When you're checking for every spine nerve and which one is sensory, motor, and reflexive. I made a summary, however, it's not enough for a summary. You have to go back and read the neurovascular status. So for the sensory neurovascular status, always start with the sensory, then a motor. For this step, you have to examine each nerve and its function. So for the cervical spine examination, we always check for sensory, motor, and then reflexes. For the sensory, we start from C5 until T2. Now for C5, you check the sensitivity of the lateral aspect of the shoulder, or sometimes the deltoid area. And what does the motor function, you do a shoulder abduction. So you ask the patient to do it against resistance, as you do in neurological examination in medicine. So ask the patient to do abduction against resistance. And then you do a reflex, brachial reflex, which is biceps. Another example is C6, which is the lateral aspects of the forearm and the thumb and the index. So as it does that is to ask the patient to elbow flex and wrist extension. So ask the patient to push against resistance for the elbow flexion and then wrist extension. And what does that is called the brachyradial reflex, which is responsible for pronation and supination of the forearm. Or sometimes I tell the students that the sensory always check for the radial sides of the forearm with the fourth and the fifth finger. So this is basically how the C6 is innervating. C7 is the middle finger. What that is elbow extension, wrist flexion, finger extension, and you can check the reflex by triceps reflex. And then you have C8, which is the little finger and medial aspect of the forearm, fingers flexion, and the T1, which is the ulnar side of the forearm, and medial aspect of the arm. It does that. It's finger abduction and adduction, and the T2 is the axilla. Now for the lumbar spine examination, L1 is representing the inguinal ligament. The L2 is anterior aspect of the upper half of the thigh. L3, which is anterior aspect of the lower half of the thigh, anterior knee. L4, L5, S1, and then you have S2, which is the posterior thigh. So these are, I'll leave the table to you to read. But however, it's almost important when you check neurovascular status, always check for sensory, starting with temperature. You check on both sides, like there's any change in temperature, light touch. Using first with cotton balls. You use the spinous process, the sternum as a reference point if you can feel the patient, and also the same feeling as same on both sides when you feel the cotton. Then you take a neurological pin, same steps, and then you check for proprioception of the fingers. This is very common when you do a neurovascular status examination in the spine, as is almost similar to the neurological examination in medicine. For motor, you start with muscle power against resistance, comparing between the upper two limbs for cervical on the lower two limbs for lumbar with this tone and reflexes, as I mentioned earlier. So muscle power against resistance, you ask a patient to do a certain step. Let's say, for example, if a hip flexion, you push against resistance and see how much he scores out of 5. Then the tone, you check if he's moving. And then reflexes, you check the reflex. So this is pictures of how the dermatomes work. So this is a scheme from the book, and this also reflexes and C5, C6, C7, and there's a dermatomes of lower limbs, and there's a reflexes for lumbar spine. So these are very important. And this is a picture of how do you do a motor examination from the book. So I took the pages from the book, as I mentioned earlier, and I put it here. However, still you need to put them back. So what I did is that every picture I took from the book, I wrote notes on it. So which functions you've been assessing, and which nerve is involvement, and which lumbar area, and which muscle are involved in this step. So this is the cervical region. The middle is the lumbar region, and also on the right is also lumbar region. Then also they have the L5, the continuation with the S1, and you have the S1 neurological level, and you have the S2, S3, S4, S5, which is now this is important. So you have to check for cardiac equine motor examination, lumbar examination. So you check for anal tone examination for the spinal process, especially in cardiac equine, which is very important, because if a patient has a problem with the anal tone examination problem, then this is an emergency, most likely. So you have to be very careful on doing it. You have to always check and confirm. And this is how you do it: the assessing of the anal rectal tone. And it's like you're doing a DRE examination, but however, as a patient to squeeze on your finger. This is anal tone examination. There's also a pelvic cavernous reflex, which is you have to check. So you ask the patient to you stimulate the glans penis, the glans clitoris, and the gentle traction of the Foley's catheter. Sometimes when the patient is already placed on Foley's catheter in the ward, to stimulate the bladder will evoke contraction of the rectal sphincter, this is a normal situation. However, if it's absent, presents a problem, which you have to investigate later on. Now this is an extra point, but however, when we examine every patient with spine examination, we'll always have this sheet, which is called the Asia classification. So this Asia classification helps us later on when we examine the patient and we do an operate on him. Want to check also for rehab later on, and where's the level of impairment? Is the impairment only sensory, or it's only motor, or it's both, or is it normal? So we go to the upper motor neuron lesions that you encounter in cervical examination. As you know, you have to check for Hoffman's sign, spastic node, and hyperreflexia or exaggerated reflex. And then you have to palpate for the pulses, which is the radial artery, the ulnar artery, and brachial artery, which I'll show you in this video.
Positive Hoffman sign, so I'm going to take and hold his middle finger at the DIP joint, and I'm going to quickly flick the end of the finger and wash the thumb and forefinger. They kind of oppose. This finger adducts a little bit. That's a positive Hoffman sign.
Then you have to check NeuroVascular status of the lumbar spine. So you have to check for Babinski's sign or reflex, clonus, spastic tone, and hyperreflexia. And also you have to palpate for the pulses. There are two important pulses we have to check. There's also an extra pulse, which is the popliteal artery. However, it's very difficult to palpate, which I'll not mention it now. This is an important one in the lumbar spine. You have to check for these two pulses, which is dorsalis pedis artery and the posterior tibialis artery. Now, when you locate the dorsalis pedis artery, so you always go to the lateral of the extensor hallucis longus tendon. They always love to mention this this statement when you palpate for dorsalis pedis Or sometimes they tell you, you tell them, between the first and second metatarsal bones. But however, the best one to say to the examiner is the lateral extensor hallucis longus tendon, and you palpate for the salspedes artery. Now, posterior tibial artery is usually the midpoint between the calcaneus bone of the foot and the medial malleolus. Or sometimes they tell you 2 centimeter posterior and 2 centimeter inferior to medial malleolus. Now check for the clonus.
This video will introduce you to clonus. Clonus is something that is seen in upper motor neuron lesions during spasticity of muscles and spasticity of nerves. To perform a clonus test, you'll want to support the distal end of the lower extremity of the patient, and with your other hand, you want to forcibly dorsiflex the patient's foot, like so. During an upper motor neuron lesion, in what's called clonus, the patient's foot will then plantar flex uncontrollably.
So this is the clonus. Now go
To test for the Babinski sign, run a pointed object from the heel along the lateral aspect of the foot forwards towards the great toe. In a normal human being, it will result in the flexor reflex or grasping of the toes. The Babinski sign or reflex is a pathological reflex and is characterized by extension of the big toe and abduction of the other toes, which is also called the fan sign or signe de levante.
So this is the NeuroVascular Status lumbar spine. So finally, we end the major steps of the examination with a special test. Now for the cervical spine examination, the special test, you always check for nerve root compression and the spinal compression. So it's one test per each point to examine. So start with the spelling test. So these steps are very important, and you have to be very careful when you do it, because if you do them wrongly, you'll break someone's neck. And I'm not joking at this point. This is very serious. So you have to be very careful when you do it. So in spelling test, you ask the patient to turn a patient's head to the affected side with slight extension. So let's say you want to examine lateral flexion with slight extension, then apply downward pressure on the top of the patient's head. Don't press forcefully, as I mentioned again, because you will break his neck. So you have to be very careful. A positive spelling sign is when the pain arises from the neck, radiating to the direction of the corresponding dermatome ipsilaterally. This means that this patient have cervical radiculopathy, not myelopathy. There is a difference. Radiculopathy means the nerve involvement or the brachial area of that involvement. Let's say a C5 or C6. Let's say a C6 involvement of that specific region will affect the sensory, motor, and the reflex in relation to that region, or say only the sensory and the motor. However, in spinal compression, Lermé sign or test is they basically do an electrical sensation that runs down the back into the limbs. In many patients, this is elicited by bending the patient's head forward. Now, this is called cervical myelopathy, which involves multiple signs. This is not restricted to one nerve. It has multiple signs. It can involve multiple areas involvement. So you have to be very careful when you compare between each, and you always have to get the positive sign. So start first with starting
for Sperling's test. What you're going to be doing is you're going to be asking the patient to extend their head, rotate to one side, and add a compression force down towards the inferior part of their body. Then you would also repeat, extend, rotate to the other side, and add a compression. What you're going to be doing is this is testing for cervical neuropathies. And if you're pinching the spinal cord, that could indicate tingling or pain going down to their lower arm.
Next, we'll go for Lermet's test for cervical myelopathy or spinal cord compression. So this is how you do it. You ask the patient to bend his head, to bend his neck forward, or bend him forward, and check if he has any shooting pain at the back. Now another test, the final special test in lumbar spine examination is only one test, and you already did it in third year rotation, or we call it the straight leg rise, or les aiguilles Lasagos sign. When the patient is lying supine on the examination bed, you ask the patient that you will be lifting the patient's leg passively. So you lift the patient's leg, so on an extension hip, and the knee extended, and when you flex the hip, the positive sign you between the 30 and 70 degrees angle. If you experience sciatic pain, this is very important to remember this angle. And test positive, and possibly there's a herniated disc. Most likely it's a cause of pain. Now, a common question that you may be asked during this station, as in an orthopedic examination, you'll be asked most likely during the stations if there's not enough time during the station, or sometimes after you finish the examinations, depending on the examiner himself, on the situation present. What I encounter during my exam, or most in the spine, is sometimes they'll tell you that the patient came to you from road traffic accident, let's say 24-year-old gentleman, or presents to you from with an ambulance, or sometimes on the highways, and they'll ask you to place a neck seat collar on this patient. The ambulance will do that, but you as a doctor, you have to do it. So you ask to do a seat collar or on the patient's neck. The most common seat collar that you'll encounter during the practice is two seat collars: the Philadelphia and the J collar, which is you can see in the emergency department or in the ambulance. You ask any ambulance team or staff, they'll show you the seat collar and how do you do it. So this is how the Philadelphia seat collar that you will be putting during the exam. And you might be asked also in the same station, to do a Canadian criteria or Nexus classification C-spine imaging. You'll be asked questions in how do you this imaging is cleared, or when do you not necessarily to do imaging on this patient, etc. And sometimes they'll give you a scenario of a caudal equina syndrome as an emergency, let's say as an ELOP or as an examination station. So you have to be very precise when you do that, when you're reading about it, and very careful when you're performing it. And a seat collar is helpful in stabilizing the patient's neck. It's very important. You want to stabilize the patient's neck. You don't want them to move to the right, to the left, as you might exaggerate the injury of the spine. And this is the end of the presentation, and thank you for your attention. If you have any more questions, ask them in the comments below in the video, or send me an email to orthopedicsart@gmail.com. Now, some students asked me what are the best references to study from in orthopedics rotation. I use multiple references. Use Toronto Notes 2020, the orthopedics chapter. It's an excellent book for the MCTQE Part 1 and for studying in surgery. It's a very excellent book. Another book you have to use during the rotation is the Orthopedics Clinical Examination, which is the booklet by Dr. Ali Chiragh. This is a must. You have to study from it. Every single point mentioned in the examination, they always mention it from this booklet. And there's also an orthopedics summary booklet released by Dr. Abdurrahman Al-Ashqar. At my time, I didn't have it, so I basically studied from the notes I took from the hospital, the Toronto Notes, Orthopedics Clinical Examination, and I used Orthopedics Bullet's website. It's a very excellent website. However, it's used for residents, but it can help students in let's say in history and physical examination, physical science, and imaging, to help how to furthermore study for orthopedics rotation. And there's also, I'll be releasing soon a text on sports medicine summary, as it is important for you to know a bit on sports medicine, or like say ACL injuries, PCL injuries,